Now, a very good morning, good afternoon, good evening to everyone. This is again another session where we cover many different time zones from Canada to Indonesia. I see people logging on from all over the world, which is great. Welcome back to session 16 of the fourth day of the International Conference on Inclusive Insurance. Today is around, we will discuss digitization, facilitating inclusive insurance, and that session focuses on digital health. In that session, we invited 3 speakers that submitted a proposal that was accepted by the steering committee. And that is a very broad range of presentations and different topics, and I'm really looking forward to that. Welcome also Denis Garon, President of DJA in Canada. Thank you, Denis, for staying up in the middle of the night for us to facilitate that session. We really appreciate that. Now, before we start, just a quick walk through the housekeeping. Most of you may have heard that already. Please keep muted unless you're speaking. We will be recording this session and we will make that session available after the conference. If you have a question, put it in the Q&A. In my case, it says F&A, so depending on your language. So in the question part, if you have a comment, you can put it in the chat. If you want to make a comment to everyone, make sure you really send it to everyone and not to an individual person. Now, for any technical issues, please message the MIN executive team via the chat. And I think that is all from my side. Thank you again to the panelists for being with us today. And Denis, the microphone is yours.
Okay, well, thank you, everybody, and greetings for this session. We have 3 interesting speakers, and we hope to have some discussion, and we also hope to have your participation in this session to enhance the discussion. So first of all, we're going to start off with Dante Portula. He's a senior financial advisor for GIZ in the Philippines and has been working in that role for several years. Followed by Mikael Mahul, who is probably well known to a lot of people, having worked with the ILO Innovation Facility for many years and now with AXA with the emerging customer market. And our third speaker will be Saurabh Sharma with Britam in Director of Emerging Consumers. So their full CVs are available on the website of this conference, so I won't go further into that so that we have more time for discussion. So we'll turn it over to Dante to introduce his topic. And the intention is to have each of them present their topics, and then we will open the floor to a discussion.
All right, so while waiting a bit for the slides to come to the screen.
There they are.
All right, so thank you, Denis, for bringing us together in this panel, and good day also everyone. I only have actually 4 slides here where I will discuss the results, challenges, and lessons of a telemedicine or telehealth project that I am managing in the Philippines in this time of the pandemic. So we all know that mobility of people is constrained due to the imposed community quarantine. People are also afraid to visit hospitals, clinics to seek for preventive and or curative healthcare. So these are the problem that the project on telemedicine wants to address by creating an efficient technology-based platform for healthcare delivery, especially targeted for the low-income sector. So the next slide, please. Next. So, all right. So here are the 5 major stakeholders of the project. So I start from the left. Of course, this is GIZ, which is an international technical cooperation agency. We are commissioned by BMZ, the German Ministry for Economic Cooperation and Development. And then you see also another logo on top of GIZ. This is the so-called Develop, which is a public and private partnership. It's an instrument inside GIZ where we bring in private companies. So it's PPP, GIZ being the public company, and then we bring in private sector into a project. So the main role here of GIZ is to provide funding and then technical assistance to the project. And GIZ also oversees the implementation and monitors the progress of the project. And then the next stakeholder here is called CHMF, or popularly known as One Co-op Health. So One Co-op Health is a health maintenance organization in the Philippines. This is owned by primary cooperatives. CHMF here is a co-implementer of the project. They also put in 50% of the project resources, project budget, and therefore it's a PPP. Moving towards the bottom right, we have the Consulta MD, which is a private company that is currently providing the telemedicine platform for the policyholders of the CHMF or One Co-op Health. And then at the bottom are the rural health units, which are managed by the local government units. We call it LGUs. So here RHUs provide support in promoting telemedicine based on its mandate for health referral system based on the Universal Healthcare Law. So the rural health units also here provide a better internet connectivity, which I'll also discuss a bit later in terms of challenges, so that those many people in the rural areas can also ease up in terms of lack of access or even weak internet connectivity. And finally, major stakeholder is the so-called NTC, National Telehealth Center. So NTC is a university-based think tank and resource center on telehealth. The center here conducted policy studies on telehealth, and then they are also leading in the advocacy in improving the enabling environment for the safe practice and sustainable practice of telehealth. So 5 major stakeholders here. Next slide, please. So here are the key results so far. I say so far because this is the first 12 months of project implementation. So we have so far 15,000 subscriber of the telemedicine platform. These are from 116 cooperatives. Actually, CHMF, One Co-op Health, they have a total of 54,000 members, but we have targeted 15,000 for this project. Out of this 15,000, since February 2021, around 500 have already used this platform, mainly on general medicine consultation, including some purpose for seeking doctor certification on comorbidities as a requirement in the vaccination program against COVID-19. And then moving on to number 2, we have also under the project created materials such as brochures, posters, short videos, social media posts in order to raise awareness, which is low at the moment, of cooperative members, and then to increase also the trust in using telemedicine as an alternative or as a supplement to the traditional bedside healthcare delivery. And then we also develop and launch an open source telemedicine application. So later I'll explain the relationship between the current platform and this open source telemedicine platform. This is actually aimed for providing not only CHMF, but other health insurance providers a capacity for offering telemedicine through this open platform, especially those companies that are targeting the low-income sector. And then we move into the number 4. There needs to be to conduct a training, since this is a new instrument in one co-op health. So we did train clinicians and the staff on how to manage the telemedicine platform, not only in terms of the technology aspect, but also in terms of the importance of data privacy, how to conduct proper virtual health consultation. And the last two outputs there refers to bringing this project in terms of information into the wider into a broader stakeholder groups, since the mandate of GIZ also being a publicly owned company by the German government is to create public goods, not only specific to certain player. Moving to the next slide. So here are the challenges so far. Here I group the challenges into 3 clusters. The acceptance challenge, the technical challenge, and the so-called cultural challenge. So let me walk through quickly on each of these. Like the acceptance challenge, this is about the newness of the service, telemedicine being new to many of these. So as this service was very new for most members, they were not actually comfortable in trying online consultations as compared to the traditional face-to-face discussion with their doctors. So the aspect of change here caused resistance in terms of acceptance. And here we continue literacy and promotion of use cases so that more people develop trust of this service. Data privacy concern is an issue. The clients are reluctant in signing up on the application with their information, and there is hesitation when sharing this online. While the information or orientation we did was we emphasize in terms of compliance to data privacy law in the Philippines, that this is also being monitored by the Data Privacy Commission, but still this concern is there. And then the application usage. So here there also needs to orient them more, because this is a technology, especially for older group of people. They are not comfortable using technology. And the project actually based on analytics, the age bracket of the callers so far from this project is between 26 to 35 years old. So it actually confirms that this is more subscribed by the millennials. Now we move into the technical challenge. Here is about the app development. Here there are actually 2 issues here. The project was very short-lived period because it is about a response to COVID-19. And then we also aim for developing an open source application. The issue here was trying to find the local IT company that could develop this in a short period of time. This is still ongoing. We are close towards launching this, deploying this. However, the existing telemedicine provider in the name of Consulta MD is continuously providing the service already. We brought them in at the beginning of the project. We have poor internet connection. I think this is also true not only in the Philippines, but also in the many other jurisdictions. And here, the smartphone dependency. So this platform, this technology works in smartphone. In the Philippines, the penetration of smartphone is a bit high, 72%, but still there is this gap that some of these members of cooperatives don't have the smartphone. Well, they can borrow from their daughters or sons. And then finally, the cultural challenge is openness to change. This is a bit related to the newness of the service. So this here in the Philippines, particular also, there's a bit, resistance to change. So they would like to stick to existing ways of doing things. Now, next slide, to my final slide, is about lessons and recommendations. With 12 months implementation, we can already offer here 5 lessons and recommendations. One is we have to provide sufficient timeline for developing the app. Mentioned in the challenge, this is like a conflict between a short period project and a complex technology development. So our strategy here was actually to bring in from the start of the project already established telemedicine provider, while in the long term we want to develop an open source. So these two things runs in parallel. And second is the provision of contents for smooth onboarding. This also address the issue of this technology is new, so it needs like video demonstration on how to use the app, so that the users, members of cooperative, feel more comfortable on how to navigate in this technology-based solution. Number 3, we need to find use cases so that other members can sign up, they get comfortable. Here, there is a very interesting use case that arose from this project. This is about getting approval for COVID-19 vaccination. They sign up, they say they have comorbidity, they get doctor certification, and then immediately they qualified for COVID vaccination. And then focus on data privacy. This always comes, this is repeating, even if we are saying that, of course, this is compliant to data privacy law. This is also being monitored by the commission, Data Privacy Commission, but still we have to repeat this. We focus on, we do brochures, we also conduct demonstration calls just to ease up their worry about data privacy. And finally, having a backup solution. Very tricky here, especially in areas where internet connection is low. The Consulta MD has a backup solution on this, because there are certain cases where the consultation got interrupted, but the system allows to continue this by way of still calling through the landline phone or mobile phone. So this is explained in the process of Consulta MD, and this is also being now integrated in the open source app that we are almost ready to deploy. And to my final slide. So here I would like to just say that we have resources here in the mefin.org. If those interested to see like the project brief, this describes more about the experience of the project and the studies on policies, they are there. You can also reach out to me even after this conference for any question. Thank you very much.
Thank you, Dante, for that. And while we wait for Mikhail to set up, I just think this discussion we're having on digital health is an important aspect in the whole healthcare system globally. And I think I've done quite a bit of work in the healthcare area, and it's always a challenge to make the system more efficient. So I think this platforms like this are really a good solution to helping things. But there are, of course, as you mentioned, some issues. So Mikhail, ready? I'll turn it over to you.
Thanks, Tini. Hi, everyone. I see, in fact, lots of friends on the participant list, so it'll be much more fun to be in Jamaica now. But But really, thanks so much for Munich Re Foundation and the Microinsurance Network for putting this conference together online. It's good to have this annual check-in. So I work for AXA Emerging Customers. We basically help AXA entities in emerging markets to develop products for low and middle income people. We work currently across 10 markets. Among other things, I'm also in charge of our digital health agenda. So I will just give you a quick overview of digital health for low-income people in emerging markets today, and then I'll basically dive into the three case studies from Egypt, Thailand, and Indonesia, and I'll just wrap up with some lessons that we learned so far. I think it's important to really embed all this discussion in the behaviors and needs of emerging customers for health services. I think these trends are important and patterns are important for two reasons. One is basically that they give us an idea about what are the opportunities for digital health and how digital health can complement other physical health services. But the other thing is that there's a huge difference between health behaviors of mass consumer and affluent consumers, and there are many telemedicine providers that are really having a hard time to engage with the mass market. So very quickly, as most of you know, I'm sure, the situation now with emerging customers in most of the emerging markets is that they hit by both infectious diseases, which they in fact know, and the rising tide of non-communicable diseases that they don't really know. Yeah, and the NCDs are kind of growing everywhere. The infectious diseases, I think it probably concerns mostly Sub-Saharan Africa and South Asia. But in many countries, people are kind of faced, in fact, with more health risks than before. And they know only basic facts, what it means to live healthy, but whenever you talk to them on the ground, they really aspire to know more. The self-medication is a first call, and often people use traditional medicine or paracetamol, and they will often go to the chemist or pharmacy to get advice or buy drugs directly. So I think as a health insurer, we need to understand that our competition is not other health insurers. Our competition is basically chemists around the corner and paracetamol. What's really important is that, we know that, kind of labs and diagnosis is very important in the public health, but quite often tests are really perceived as doubling the price. So the low-income people, they try to avoid them. And what's really common, for example, in Nigeria is when people feel a bit sick, they will go and kind of buy malaria drugs directly. They won't really do the tests, because if they do, they would need to pay the double. Then I think in many countries, each country has a slightly different health system, but you can see that, poorer and rural segment, they will use public health, and they will quite often get good quality care. They will need to, there are waiting lines, maybe there's less empathy in the public health system, but I think in many countries this has really improved. But others will quite often go to see to the private clinics. Another thing that was in fact mentioned on the previous panel today, and which is like a huge problem for public health, is that outpatient care is quite often sought in overcrowded public hospitals, so often in emergency services, and the regular checkups are rare. And we all know that primary care is really a cornerstone of any health system, and the fact that people, whenever they kind of feel sick, they need to go, or they're going to the hospital, it's also kind of defers their decision to go to the hospital, because they don't want to spend a day. Especially when you're in the informal sector, spending a day in the hospital, it's just a loss of revenue. And the last bit, we all know it, they really have hard time to fund healthcare. I mean, the out-of-pocket expenses, depending on the country, they're still quite, they're still on the high side. So the bottom line is that, you know, emerging customers, they really forego checkups and treatments, and it leads to a kind of very bad and tragic outcomes, because they basically end up in the hospital when it's too late. And I think the case of Lydia, which is coming from Living on a Little, recent book by Julie Zolman, based on the financial diaries in Kenya, it's a very kind of typical case of a low-income person and how tragic it can get if people don't have access to healthcare. And I think what Julie is saying, and it's kind of very well coined, is that low-income people are subject to a substantial quality tax, with treatment costs escalating as individuals seek care from multiple providers to resolve even common illnesses. So you see this the story on the screen. 27 years old Lydia, living in Kenya. She was really experiencing a lingering illness. She went to the hospital at least 4 times during that year. Each time she was told she had malaria. On each visit, she would be given a new medicine. After showing no improvement, she started going to private clinics, but didn't help either. And as a last resort, she turned to traditional medicine. What you see on the picture, it's not Kenya, it's Nigeria, but that's basically Agbo in Nigeria, and no matter your income status, in fact, everyone uses it. And her condition really continued to worsen. And just before dying, Lydia, she was diagnosed with very late stage tuberculosis. And to be honest, I mean, it's when you have a good GP, it's quite easy to detect TB. And TB care, like in many countries, in everywhere in the world, is free in Kenya. So in a way, it just shows the story that you know, if you don't have really someone who helps you to guide you through the health system, even if you're trying to kind of get the treatment, you might really end up in a very bad situation. And I think when you look at our work in digital health, it's mostly telemedicine at the moment, but I think it's important to understand that our ambition is basically to help our customers in emerging markets, to help them to navigate the everyday health. As you see in the screen, our work, it has 4 main components. One is really about the health engagement, you know, tips, health tips on your mobile phone, targeted to specific groups, to specific conditions. Then the second piece is really the backbone, is the kind of remote access to care, and that's mostly telemedicine. It's chat a doctor. It's also making sure that there is a medical record there, electronic medical record, which is kind of used by all these doctors for a kind of consistent care provision. And the third piece is more a bit like a play between digital and physical. I think it's also making access easy for labs, for drugs, for appointments with specialists. And I think it's an important piece to make sure that people really go to the right place when they need to go there. And the last piece is insurance, and I think it's really a last piece. So we have more and more bundled products when we bundle low-ticket health insurance with digital health, and I think the actual kind of health ecosystem that we try to create is probably more important than the insurance piece. But it also helps us to make insurance much more tangible. So that's the problem that many of us are facing when we're selling insurance to low-income people, is that's the most intangible thing in the world. So having the health services and having a way for people to test you at any time has a kind of really like a huge, it's a huge help in insurance discovery and customer loyalty. COVID, like for everyone in the world involved in this field, really accelerated our agenda. We work on this before COVID, but in the beginning of last year, we maybe had like 2 pilots in the portfolio. We ended the year with 15 schemes across 9 countries, reaching almost 2 million customers. We managed to get like 300,000 people enrolled, so actively enrolled and giving us consent. And quite many of them, in fact, used them. We had last year, we have 76,000 consultations. Just very quickly, I'll just show you 3 cases. I think it's important also to understand that you can do digital health in a low-cost environment. I mean, each country has a different cost structure, but we usually, you can easily get a kind of really decent service for 30 cents per user per month. The first case is the one that we started quite a long time ago, in fact, with AlloDoctor. AlloDoctor is it's basically a health portal, and they also have a doc function. So it's a very good telemedicine player, very well established, and probably the biggest kind of resource on health in Bahasa in Indonesia. They started cross-selling our insurance, but as a bundle. So if you buy insurance, you also get a free access to a chat doctor function. You can see the results. This is last year. So every month we had more or less like 50,000 people on it. And of course, sign up, when I mean sign up, because as Dante said, I mean, signing people up to this is also a challenge. It's not just utilization later on. So sign up here is automatic because it's within the AlloDoctor ecosystem. And you can see that the usage is in fact huge. Yeah, this is quarterly usage. It means every quarter, 1/3 of the customers basically engage with the service. Yeah, so this is the unique usage. The second case is we used to have before COVID. I mean, we're still having collaboration with the AIS, which is the largest telco in Thailand. And the very simple kind of PA product that was kind of embedded as a freemium to kind of drive their customers' behaviors in terms of basically topping up their phones. We bundled with this like an access to a free COVID clinic on the app with a Singapore-based provider, MyDoc, who in fact we brought them to Thailand. I mean, you can see here, I mean, that's the kind of the other side of the coin, because we have some successes in our portfolio. So had a few failures, and we learned quite a lot from those failures as well. The customer base we had was quite huge, 350,000 people. Only a bit more than 500 people sign up to the service, and the usage was kind of okay among people who sign up, but I mean, compared to the customer base, it was we were not very happy about it. The last piece before I wrap up is the scheme in Egypt. So as many of you know, we work with like most of the leading microfinance institutions in Egypt. Our customer base at the moment is more than 500,000 borrowers. Basically, with 4 of the microfinance partners, we basically run a kind of 3-month pilot when we gave people unlimited teleconsultations for insured borrowers and their families. We've done it with Altibi, which is probably the most mature kind of telemedicine provider in Arabic. It's a great provider if anyone works in these countries. I think you should definitely reach out to them. And they, what would we basically the pilot kind of customer base was a bit more than 60,000 people. We managed to sign up almost 20,000, and it was all done through kind of the usual microfinance approach. So really using the loan officers, even if they were a bit stuck because of the COVID, they were kind of using their WhatsApp groups to basically get their people involved and make sure that they kind of get enrolled. But the other thing that LTB did that really helped with the sign up, that they were basically doing the welcome calls, and they were signing up people. It was of course not welcome calls with doctors, but with the admin staff. But it was quite a powerful way basically to reach out to quite poor populations and to get them interested in a new service. And you can see that the utilization, given the fact that these are really poor people, not all of them are digital. In fact, we had 10%, 11% kind of unique utilization over these 3 months, which is really quite good. I mean, it never happens if you don't push. So I think when you look at the 3 cases, the first case, I mean, it shows if you embed something, digital health in a health ecosystem, it's quite powerful, because people are already going to Allo Doctor to check on the health questions. And I think you will have quite a high usage, and it will make your bundle with insurance very, very tangible. When you look at the third case, it basically shows that if you're smart on health engagement, you will do welcome calls, you do SMS reminders, you can really achieve good signups and also achieve good utilization. And the last bit is if you just go digital and you forget that it's just impossible to go purely digital, and you ask people to download another app to use telemedicine, it's really a hard sell. It's a new service, as Dante said, people need to discover it. It doesn't happen overnight. Yeah, so I think that's probably our main lessons learned. Main lessons learned are really around kind of engagement and making people to discover the service. Yes, COVID helped, but it's a process. It's a process taking a few years. It never happens overnight. So I think, despite like low utilization in the beginning, I really encourage everyone to keep pushing, because when people discover it, they stick to it and they really use it, because they, as I explained earlier, they don't have so many other options. Rich people, they will have all the options, yeah, and all the resources to access these options. Low-income people, quite often, they really kind of use health system when things are really really bad already. So the ongoing engagement on health is key to drive utilization. Really check your telemedicine providers. Some are really good on the mass market, and we also kind of work with ConsultMD in the Philippines, Dante, and I agree they did very good provider. And the fact that they basically you can also call a fixed number, a short number, it also helps, because you don't need to be kind of digitally savvy to use it. The customer journey with just an app, I mean, we all know it. It never works. It's a very high drop off. We also work with some providers now that we basically use kind of WhatsApp, Messenger, kind of another communicators to reach out to people and enroll people. So basically you're enrolling on your favorite Messenger app, which is quite powerful, in fact, because you don't need to download something else. It's a very good kind of patient experience as well. So so this works very well. It's quite promising as well. Yeah, I can't really kind of share the numbers so much, but I think based on all the schemes we had, and we always try to embed it in our insurance to make it sustainable in the future. I think the low-cost business models with a bundle insurance and digital health are really possible when you have a product that is kind of a bit higher than €2 per month. If you go lower, then it's a bit tricky to bundle unless you kind of mark up the price. Yeah, but if you want to build an internal business case that it kind of helps with engagement, it helps with the customer acquisition, it helps to reduce the claims costs. I think for products that are kind of more than €2 per month, I think it's possible. The cross-selling insurance to telemedicine customers, it's really possible, and it's a good model. And the last thing that I just didn't have time really to talk about it today, but we're also developing quite many pilots at the moment to help people with chronic care management, and that's really a next wave. Just to give you an idea, in Thailand, you have, according to WHO, you have around 15 million with hypertension. Only half of these people are aware that they have hypertension. Among this half, only 30% of people stay on treatment. And usually, most of these people will be excluded from traditional or even mass market health insurance, because you will always have an, in most of the underwriting questions, you ask about hypertension. So I think just imagine the masses that you can include in the health system if you get the chronic care management right. And I think there are more and more kind of digital therapeutic solutions that work. It's still it's less developed than simple telemedicine, but it's coming. So it's a kind of new exciting opportunity for digital health. So I just stop here. Thanks so much again, and happy to answer any questions.
Thank you, Mikhail. We have been receiving questions in the Q&A box, and we will get to them. We already have 3 questions. One even came just as we started the session. So there's a lot of important questions coming. So the next speaker we have will be Sarab, so we'll let him set up. What Mikhail has presented and what AXA's approach is creating access. For me, when I've worked with healthcare systems, access is the most important aspect. But another important thing that I saw, Mikhail, what you're doing with AXA is also prevention or health promotion. And that also that's also a long-term solution to lowering costs, is preventing a problem before it happens, helping people understand that. And we sort of see that somewhat with COVID, and in the hand washing, wearing masks, does actually help reduce the issue. So those are really important aspects in any program. So now we'll go to Sarab.
Thank you, Denny, and a warm hello to all the attendees from a very hot Kenya at the moment. And I hope you're all enjoying this very insightful conference. So I think I'll talk about the partnership between Britam and MTIBA, and I'll flip, what Michal was speaking to around how provision of digital health in form of telemedicine can actually help in making insurance more tangible and even result in better uptake of insurance. So I'll flip that and talk about how an insurer can distribute health insurance in partnership with healthcare providers. And very quickly on the next slide about Britam and MTIBA. So Britam is an insurance group based here in Kenya, but we are the largest insurance group in East Africa with presence across 7 countries. In Kenya, we provide micro insurance or inclusive insurance to over 1 million lives, predominantly health insurance, for the simple reason, as we all know, health is the most pertinent need for customers in this segment. And then our partner in this case is MTIBA. And MTIBA is a health technology startup. So they are a health tech. They are operating mainly in sub-Saharan Africa. They started in Kenya. And it's a very interesting platform. It's a mobile health wallet. So it's, traditionally there used to be health saving account. So it's a very similar solution, but on a mobile phone. And, as you know, mobile wallets are very popular in Asia, Southeast Asia. So think of a similar solution, but mainly focused on health. So customers can register for this wallet, and then they can save money. Mainly, you can send money through M-Pesa, mobile money, into this wallet. And then using this wallet, you can access care at more than 2,000 healthcare providers, mainly outpatient or primary care, across all these providers, where MTIBA is providing, a digital interface with these providers. So using this wallet, you can go and access cash-free using the amount saved on your mobile wallet. And so we partnered with MTBA last year, and the main reason, as I said, currently MTBA caters for outpatient care, but a lot of their customers were requesting for an inpatient or hospitalization care solution as well. So we decided to come together to design an inpatient health insurance product. I'll just speak to these products very briefly. And so these products are now being sold to these MTBA customers. And today I'll talk about the product, how we are selling it, and what our experience has been so far. So in the next slide is a brief snapshot of who the target customers or who the users of MTBA are. So MTBA has 2.4 million savers. Of course, the active savers on a monthly basis varies, but those are the registered savers. And as you can see, majority of them are young, between 20 to 40 years, almost 65%, with almost 50-50 gender split. And this is the benefit of partnering with a digital distribution solution like MTBA, that the kind of customer insights that are available to an insurer. And as you will see, we have used these insights to not only design the product, but also how we are distributing this product as well. So this is the spread of customers. In terms of income, they are majority emerging customers. So we are talking about low income, lower middle income customers here. And you can see how much amount they have saved and how many claims have been paid through the saving wallet solution. So I think in the next slide, then we talk about the product itself. So as I was saying, it's a inpatient health product with sum measured between $1,000 to $2,000. We also cover maternity. And I think this is, a benefit that was added based on the customer insights. So as you can see, 65% of the customers are in that reproductive age of 20 to 40 years, and they value maternity benefit. So we added maternity benefit as well. And then a funeral cover of around $400 was added as well. And I think you can see the premiums as well. We have obviously some eligibility, waiting period conditions that I won't go into detail, but these are shared with the customer as well. So I think in the next slide, we talk about how are we going to the market with this product. I mean, we have an active customer base. We have on the mobile phones, but we still have to sell this insurance. And what kind of go-to-market models we have used. And I think I can divide them into two broad categories, assisted and self-sales. So by assisted sales, I mean that, there is some kind of an agent who is helping or assisting the customer to complete the sales, while self-service is a fully digital end-to-end customer journey. And I think even in terms of marketing, this has been different. So within assisted sales, we have used both call center and on-field agents as well. So call center marketing, as you can see, we send out SMSs with a call to action where customers can respond whether if they are interested in this product, and then with our call center, we call them back to explain more about the products, its terms and conditions, and that's how the sales is closed. The other assisted sales model that we have used is field agents, so who are actually on the field, doing these ground activations to complete sales. Finally, the self-service mode, and again, going back to the customer base of young population. So we are using social media or digital media to reach these customers as well. Social media, obviously, on we are buying Google ads or Facebook ads to create awareness about the product. And obviously, then it leads to digital portals where customers can complete the sales. I think the KYC and premium collection obviously also varies depending on that. The SMSs, the call center led model, obviously is for the existing 2.4 million MTBA users. And so we can just use that KYC as well as collect the premium which has been saved in the MTBA saving wallet. While the other channels have focused more on bringing new users. And in that cases, obviously, we are collecting the KYC and premiums afresh. And I think the success across these models has varied. As you can see, the most successful model for us so far has been the call center led model. Compared to field agent led, I think field agent model for a number of reasons, because first of all, it's expensive. And I think you are trying to target more of a mass population. While I think a call center model is mainly targeted at MTBA users. And I think that has been a very key insight for us, because obviously these customers are saving money on for their health. So they are already sort of a self-selected group out of Kenya's population of 50 million people who are keen on accessing some kind of health financing solutions. So that is the model. And when we are reaching out to them through SMSs and call center, we are able to have a better conversion rate. While I think in terms of assisted sales, the response has been lowest because we are trying to target the mass population. Direct self-service end-to-end digital sales, I would say, is somewhere in the middle, because I think obviously this is for customers who are better at understanding the product terms on their own. And that finally brings me to the key lessons from the initiative so far. And I think the first is the uptake rate. And so we have had a voluntary uptake rate of up to 14 to 16%. This is through the SMSs that we have sent out, that kind of conversion rate from the customers that we are calling. So I think this to me brings that same point again, that this self-selected sample, which is aware of the need for a health financing solution, has been a better sample for this product. Because obviously if we compare it for voluntary uptake to our other products, it's much lower, sometimes even as low as 1 to 2%. And the second idea, the second learning is around data insights. So I think this is now again bringing the same point of working with the digital partner gives you an unparalleled access to data. You already saw how we used it through customer profiling, customer segmentation to design the product, but we are even using data to inform our go-to-market approaches. To give you an example, we are trying out different types of SMSs with different languages and doing what techies call A/B testing, which simply means that sending two different SMSs and see which one gets a better response. So we are trying experimenting with SMS languages. One SMS will highlight the benefit that, hey, you get $2,000 inpatient benefit, while the other will highlight the premium that just for $32 you can get health insurance. And we see which segment is getting better response for which type of SMS. And we are using that to continuously improve that uptake rate. And I think the final learning with the initiative so far has been this hybrid go-to-market approach. I think while it's a digital platform, the need for human touch is still there. As you saw, instead of the self-service, it's the call center plus SMS model where we are getting the best response, because I think customers still want to get that human touch, obviously to try to understand the product more as well. And I think human touch just brings that assurance, that trust that just a plain SMS cannot bring. So I think that those are the learnings that we are taking so far and trying to scale it up more. And the most exciting development now is around, we have put this product on the M-Pesa app. And if you know M-Pesa, it has 40 million subscribers in Kenya. It's the largest mobile money solution on the continent. So we are hoping that now with access to this much larger population and these lessons, we can scale up this product a bit more. So that concludes my presentation. Denny, back to you.
Okay, well, thank you very much to all our three panelists. And as I said, we've had several questions. Since I'm facilitating this, I will ask the first question. In terms of access, we saw from the three different presentations, maybe different market segments, different challenges in reaching people. It seems, what type of work is needed to try to reach more people in different age groups? And I'm wondering if COVID may help push some of this change in behavior to go to access via telephone. So maybe maybe we could start with Dante. How do you see this issue?
Yes, Danny. Actually, the telemedicine project of One Co-op Health is, a kind of top up to the existing benefit package of the policyholders. I mean, without the telemedicine first, they have the inpatient care, they have the emergency treatment, they have the outpatient, they have even dental care, and then now comes COVID. Their worry was people won't go out to the clinics especially for preventive care, because this is important for them. And then curative care is already claimed. Preventive care might be better for claims management. This is where they got interested of bringing in telemedicine as a platform, so that even with restrictions in mobility, they still can serve the member, their clients, the cooperative members. So my feeling is, while we are still small in terms of utilization, that this is actually providing access to the members, to the cooperative members, because they are able to continue the consultation process. They have the access for consultation. They don't need to go to the hospitals. And one time when we were meeting, I actually asked the cooperative whether they see now some trend in terms of low utilization from the claims, meaning from the curative claims, those that go in the hospital. Because what we'd like to find out whether telemedicine has helped prevent some illness. Otherwise, if they don't go to hospital, they don't know they are sick, and then immediately they go inpatient. So this is claims. They say this is an interesting area which they can actually look from the numbers, but they have not also seen an increased utilization from the traditional benefit package.
Okay, that's right. Mikhail, if you want to take a chance. But I maybe just adding one aspect. When I first started working with telemedicine was in 2008 in India, and the issue is the rural areas have much less access and more difficulty in transportation. Are any of these programs really hitting or creating access for people in the rural area?
Yeah, I mean, it's a valid concern. It's at the end of the day, I think in terms of broader kind of your broader question, it's all about creating a health ecosystem. It's not just about telemedicine. I think telemedicine is a key part of it, but it's about health engagement. It's about preventive stuff, as you said. It's about providing people with the scans network. I think one probably the most successful and the most sustainable case of digital health for low-income people in emerging markets is the tonic scheme in Bangladesh. It was initiated by Telenor Health. Now it's with Grameen Bank. They have 8 million customers using it all the time. But what really attracted people to it was discount network. So in a way, you need to kind of understand your customer and come up with incentives for people to start using it. And basically, then I think the game is for them, whenever they get sick, that they will first think about your ecosystem and go to you for advice. In terms of kind of rural urban, or that's very similar for gender, because there's still a big gender divide. So women kind of are less digital in emerging markets. I mean, to be honest, most of the good providers, they will also have a short number, so you can use a feature phone to call. Yeah. But then you have less channels to engage with people, and the actual experience it's kind of less powerful. Yeah, but I think for us, I mean, your concern for me, it's more like a public health concern. For us, to be honest, I mean, we know that one day everyone will have a smartphone, and there are already so many people that are excluded from health services now that don't have, and they have already smartphones. That we're just working with these populations that we can reach more easily, yeah. And it will come to other areas at one point as well. And I think what's really important is the last mile. So there are quite a lot of health startups that are leveraging the community health workers, kind of either government or NGO schemes, and those community health workers are key. But if you can equip community health workers with a good digital solution, they can do much more. I mean, I agree on this.
Yeah, no, that sounds like a interesting, way to do it. And I know from working with Grameen and BRAC in Bangladesh that the community health workers were really powerful in helping direct people to an improved service at less cost. So that's good. Sarab, you had some data on gender, and I know Gilles Renoué from Women's World Banking always likes to ask the question, any insight on gender differences? So maybe Sarab and Dante and Mikhail, if you could answer both that question, and maybe also add on outcomes. Are you seeing different outcomes from people in improved health?
Thanks, Teddy. So if I may go first, I think, so in terms of gender, I would say, so we are still at early stages, but the good thing is, I think compared to a lot of other initiatives, in this case, because of availability of data, we are actually able to separate those insights. And I think what so far we have been trying to do, what I was talking about earlier, testing different behavioral biases, that whether we are testing pricing or we were even testing saliency of benefits. So it's to say that does just saying, inpatient cover. And I mean, I think a lot of people actually out there don't even know what inpatient means. So you have to say like, hospital admission, or whether maternity is a better, benefit. So which of these benefits is more appealing? So that's what we are trying to look at this point. I think, so I would say like still very early stages, but those are some of the areas where we are trying to test this across this gender line. And very shortly on the second question around outcomes, obviously I think we are not able to really look at the outcome side. But again, going back to that point of data, what we are able to do is look at, what are the causes of claims? Why are people getting admitted into the hospitals? So we are seeing that obviously, chronic diseases, for example, is a big issue because they aggravate any other conditions as well. So as Michal was talking about, so we are looking at, how do you bring in some preventive angle to this chronic disease issue as well. Thanks, Dylan.
Dante.
Yeah, I'm actually looking now at the analytics because the telemedicine platform, they provide monthly analytics. in terms of the utilization. Yeah, here, why they analyze the color, the age bracket, which I think is nice. They even analyze which day is heavy call or not. The type of consultation, which I think refers to your second question, Dene. Here, the type of consultation is mostly general medicine, and then others like pediatrics, neurology, ENT follows, but big chunk of this is about general medicine. This is also where we link the good case of linking this to COVID-19 comorbidities and vaccination. The breakdown by consultation, they are also analyzing it, whether it is in the morning, afternoon, or evening, mostly in the morning. Unfortunately, there is no analysis on the gender side. Of course, GICIT is interested into this, but my feeling, actually, this can easily be generated. Immediate next step from my side is we can ask the service provider on this to include this in their monthly analytics report, trying to disaggregate male and female.
Okay, so there's work to do on that. One of the first questions we actually had in the beginning of the session was from Panfino de la Paz, asking, are claims filed digitally? And how do you detect fraudulent claims? So I think that's maybe, Sarab, your products seem to be paying a claim for hospitalization and things like that. So in the other ones, there seem to be more service products. So maybe, is that something you could answer?
Yes, so very quickly, so the claims are done digitally because I was saying that MTBA is actually a payment ecosystem. So how it works is that customers, have MTBA on their mobile wallet, on their mobile phones at the provider, and there is like a small machine which verifies that information, and when the claims are done, they are sent to Britam through this digital platform. So I think in terms of inpatient fraud management is easier, as customer is actually admitted on an average in Kenya like between 4 to 5 days. So the chances of fraud are less. In outpatient, in some of the programs we do outpatient, is a lot more. I think very quickly on fraud, it's a bit of analytics based and also care management. So we actually have a team of care professionals who review and vet these claims. So they actually check, and so fraud is more in terms of what we call upcoding, where a hospital would just add certain treatments which should not be there for that condition. So that's how we try to control that, a mix of analytics and a care management team.
Okay. I think we saw, I have a question here from Catherine Bullemacher, the Executive Director of the Microinsurance Network, and I'll paraphrase maybe the question. Most micro health insurance seems to be focusing on hospital care and cash, and so by the time somebody gets to the hospital, it's already too late. In some of these digital health solutions, they seem to be creating access to initial consultation. So, how do we bring these together? Because these initial consultations may help reduce the need for hospitalizations. I could think of malaria, if that was tested earlier and somebody knew about it earlier and took the right treatment earlier, that they wouldn't end up in a hospital situation. So how do you see the solutions here helping to complement and improve the whole healthcare delivery? I'll leave it open for whoever wants to answer that.
I think it's a good question. Basically, I mean, if you bundle telemedicine or more broadly digital health with an inpatient health insurance product or hospital cash, you're basically creating a solution for people to access primary care, because most of the digital health consultations, it's all about primary care. which kind of also includes sending people to the right place to do the test, the right test. And it's also sending people to specialists if they need to. So I think, of course, we're realistic, and people always would like to see the star doctor in person, but so it takes time, this behavior change. But if you get it right with the right telemedicine provider, I think you can basically create a good alternative to access primary care. We also have some, basically, then outpatient insurance is tricky, as we all know, and it can get just too expensive as well. For our target base. But in Indonesia, for example, we're launching a kind of limited outpatient, full inpatient health insurance program, which is also done with another telemedicine provider. And basically in the package, we will have like physical consultations for outpatient limited, but in the package, we'll also have basically some specialist consultations online. Some drugs will be covered in the package and delivered, and some tests will be covered as well. Yeah, so in a way, then you're creating quite a comprehensive protection product, and you can basically two things: you can steer people to use kind of online consultations when it's appropriate rather than physical consultations. And you can also do the digital triage on kind of a gatekeeping approach, and that people contact you before they go to the hospital. They will need to go through your kind of digital triage. So then you have a bit more control over what's going on.
Dante or Saurabh, have anything you'd like to add?
In the case of the One Co-op Health, the telemedicine here is, we can call it also a bundle, because there is an existing package of benefits. I already mentioned inpatient is there, outpatient is there, and then emergency treatment. So this is a kind of a top-up service to the existing 54,000 policy holders of the company. So here, actually, this doesn't have an additional cost to the policy holders. But even then, actually, our learnings when we were designing this project, that this is going to be an easy uptake, because imagine, this is free, but we were actually wrong. It takes a lot of effort to convince people to sign up, even if the package is already there, and here is a top up, and this is good for the situation now of pandemic. They can't go out, but there is a technology where they can continue the consultation.
Saurabh?
So I think going away from MTBA, so we also introduced a telemedicine solution last year. I think the reason was we were seeing a very high drop of utilization in our health insurance. In fact, first COVID case in Kenya was reported in 15th March. And within that 3-4 months, the health insurance claims had dropped by 30% because people were so reluctant to go to hospitals. So obviously, on one side, you can say that health insurers are happy about lowering claim ratios, but we were also talking about like how do we engage our customers at this time. So we did launch a telemedicine solution, and we had very interesting insight. I think similar to Dante, right? So what we are seeing is a steady but low level of adoption of telemedicine. And it's very interesting that we insure people in groups. So certain groups were more likely to use a digital, like a telemedicine solution. For example, security guards. So we insure a lot of security guards in Nairobi itself. And these guys were using telemedicine disproportionately higher than other groups, which, you can infer that maybe these guys are spending more time at their site. And that's why. So what the takeaway for us was that we want to, just a general telemedicine solution may not get the kind of adoption. So you need to target specific segments. So what we are working on right now is a telemedicine specifically focused on maternal care. You try to target the specific segment of expecting or new mothers and provide this kind of advisory plus consultation. So that is, we think, can improve the adoption a bit more, having a more targeted base, a customer centric kind of telemedicine offering. Yeah.
So, another question for you from Joshua Fisher was, is MTIBA product accompanied by a physical card? And do providers confirm availability of funds insurance coverage?
No, so there is no physical card. MTIBA is, as I said, it's a mobile wallet. So customers can use both USSD or an app. So USSD, you just dial in, which actually shows, how much, whether your cover is active or inactive, and how much sum assured a balance amount is remaining. So customer can actually show that to the hospital, who can then verify it on their own and on the MTIBA portal as well. So there is no physical card, but only the mobile validation.
And then another question from Manjov Pandey from Access to Insurance. Part of it, the question was on gender. I think we've asked that, but an interesting part of his question was, what is the disaggregate data would be relevant when you're targeting women? What data should you be collecting?
So is that for me?
For you and everybody, yes, I guess I would ask everybody.
Yeah, I think data is very interesting, right? So when we talk to our actuaries, they want to collect all sort of data, but our operation people are pushing back. They are saying there is a limit to the amount of data that you can collect, right? Because it has implications. If you're talking at the onboarding time, the number of fields you are adding for customers to collect, or if you're talking about claims, even adding more fields makes it more complicated. But I think basic data is really around customer profiling. And that's why we are seeing the benefit of working with these players like MTIBA, right? So we are working with a number of other players, which I call them as like platform economy players. So they are able to give you data which you not necessarily need to ask for on the insurance forms only, right? So who are these customers? Where are they based? So you can do a lot around that. So that, I think, for me is like in a more traditional channel is more difficult, but these platforms are making that data collection a bit easier. And specifically, like what type of data, I think that customer centricity around, profile or segmentation of customer can be very useful for both product design and go to market.
Ante or Mikael, would you like to add?
Not really. I mean, these are all mass schemes. It's not that we really target segment. Then when you have the health data, and kind of Dante alluded to it, it really depends. If you have like in-house on digital health services, then you have full data because you own it as well. But quite often in AXA, even if it's in-house, it's another entity. So it's not that we as an AXA insurance, we have all the data, it stays with the health providers. Yeah. And I think when you have data, you can do much more, but it's more to basically fine tune the product. I think to target women, really, I mean, the most important thing is in fact to start targeting women and really do something about it, because they are agents of change, especially for health, and they take care of all the family members. So that's really important. But you can basically come up with a very specific service bundles that will target women. So it's sexual health for young girls, it's maternal health for women, but maternal health, you need to also understand, in most of the countries, you will have a vertical programs that are quite good by the government. So I need to see how you can complement it, basically.
Yeah, from my point, then actually, because this is a very good question, because earlier I said that I think it can go into the analytics. Maybe they can collect this easily, especially if it is just gender, male and female. But again, if we would collect more than that, my thinking now is we have also to convince our private sector partner, the insurance company, what is what's what does it make sense for them, unless they are trying, to develop products that is targeted like maternal health care. So otherwise, while we want to collect data on women, but also from our experience, not only on health products, we also, think twice when we want to discuss this with insurance providers, even with insurance regulator that actually collects this information on a regular basis, whether this makes sense for the players, for the industry, because for their side, this is also an additional resources, additional task, be it a manual or a digital platform. It also needs to be created. And just one point from my side, also from the thoughts of Sharab about doing some targeted products for certain sector. I don't know how it works in your telemedicine experience, but here in the Philippines, in our project, we did not have that discussion because the platform, they have different specializations, meaning there are doctors there. While the analytics now shows that the utilization is mostly on general medicine, but there are other specialists there. There is a pediatrician, there is neurologist, there is even ENT. Uh, but in terms of cost from the CHM side, it doesn't make any difference. Meaning whether they put on board a pediatrician because we'd like to target more women, doesn't. I mean, I don't know if I'm clear, but we can create different different target groups by inviting different specialists, physicians to the telemedicine platform. That's what I'd like to say.
Okay. Well, I assume all of you are collecting the gender data, which is, of course, one of the key items to understand. But also, Dante, if you're collecting more detailed data on the types of conditions, it might lead to the possibility of doing health promotion methods or messages to the client base to help reduce issues. If, for example, if you're seeing in one area malaria coming in, that help people, look at purchasing insecticide-treated bed nests and things like that. But anyways, so I think that the data source, yes, it's always a challenge to get the right balance between too much data and too little. If you get the right amount of data, then you should be able to also not just target the product, but also target how you can help reduce some of these claims. So, okay, so we have another question here from Manyak Madan. How are you centralizing operations for telemedicine or call centers for different countries using own infrastructure or global cloud telephony provider for omni-channel customer service and call center operators? So I guess, Mikhail, you're in several countries, and Sarab, maybe you can answer that.
I think it's country by country, because also, kind of data regulations will differ. So we either have in-house solutions in a given country, or we work with providers who are already active in this country. I don't believe there's nothing like global digital hub phone line, and maybe for rich people, but not for our segment.
Sarab, are you also in several countries, or?
No, so primarily our telemedicine solution is in Kenya, and in fact, we work with external healthcare providers. We don't do it in-house. So we work with external care providers who are actually offering the service to our clients.
So a question here from Prashad at the ILO facility. He's wondering how much investment and how long does it take to break even and reach sustainability on a telemedicine initiative?
It's a good question. I mean, basically, we are really in the kind of test and learn phase. So, I mean, of course, we always develop all these business cases, but I think what's really important is to have a small budget for engagement, because if you don't have it, then it won't fly, you know. So, but even with a budget of 20,000 euros, I mean, you can really do enough in the beginning to make it work. Yeah. So and then later on, when you have kind of the right digital channels, especially the kind of integration with WhatsApp, other messenger services, then I think your cost will really go down. And then you have on the content that you can kind of keep reusing and targeting different people. So it's a bit of investment in the beginning, but it's not huge. And to be honest, if you get things right, you can probably break even very fast.
I sort of wonder if we're sort of at the same point where when mobile phones were first introduced, this is a chance for an opportunity to do something very different. And my study of pandemics in the past for society has always been transformative events. 10 years later, society was quite different. Because so a pandemic can help maybe push some of this change. I guess I'm hoping for that. I do see it as a positive solution. Okay. Yeah, go ahead.
Just a few words on this. Of course, we have not CHMF, Funco of Health. They have not looked at the numbers here, but I think the decision point from them to put this as a top up is something already. Of course, there is there to serve their members, especially this time of pandemic. But one thing that we learn in terms of contract here, because the service provider is commercial, and then they accepted this contract, and this is free for their existing policy holders. The contract type is, for example, it's 15,000 clients. They have to pay all together the 15,000, whether they utilize it or not. So to us, this is also a realization that we need to, we need to gear up. We need to speed up the onboarding, because there is cost already there. I don't know how does it look in terms of pricing in the other experience, other country, but this is how it is in the project.
We're running out of time here, and unfortunately, I don't think we can get to all the questions, but I see a question here from Bert. I think that's a good way to summarize Bert Optipek, sorry, my full name. And I hope I pronounced your full name correct. I still always have problems with your name. What's next? What are the new developments in digital health insurance you're excited about? So we could use that as a wrap-up question. Each of you can take a shot at that.
I think I already mentioned it. For me, it's chronic care and all the kind of digital therapeutic solutions that can help us people to basically stay on treatment, and also help our actuaries to accept them to health insurance. So that can be quite powerful, and it's a bit behind the telemedicine. But the last thing I want to say is that, I mean, still telemedicine is not there. I know governments, they have hotlines, I mean, but the usage is still very low. So I think the game is still to keep pushing for engagement. And I think we just need to basically create incentives for people to also move to the online space for health.
Denny, I think from my side, from here, from the experience of the project, we need to work more on the regulatory policy aspect. While Philippines is a bit relatively advanced in terms of policy, but consolidating this, like for example, interoperability of this information, this digital data, electronic data it's still a tricky part here, especially if we want to put this together, government uh, data hub and then the private sector, so that we have a large pool of electronic health data. This needs a clearer policy direction from the government.
Rob?
Right. So I think for me, see, digital health still has a lot of behavioral barriers. That's what we have seen. Last year during COVID, I think the number of digital health launches in Kenya, really escalated. But now, like almost 1.5 year later, I think a lot of them have not got traction. In fact, the number of, I was talking about the number of hospital claims going down. They are back with the vengeance. Our number of hospital visits have increased this year. So that means that there was some change, at least from the supply side for digital health. But I think from the demand side, these behavioral barriers, we still need to work on them. And Dante said it, right? We need that public policy intervention, because private sectors would always be working on very specific groups. But the most exciting thing for me is about health ecosystems. I think we need to, it can't be just like one audio telemedicine consultation solution. We launched something like that in India in my previous career, like 8 years ago. But now what we are seeing is we need to talk about ecosystem. So how do we bring diagnostics and drugs, and only then customers will see it as an end-to-end service. We are seeing some interesting ecosystems like peer-to-peer, so doctor-to-doctor teleconsultation, because some of the northern Kenya remote parts where specialist doctors are not available. So general physicians are actually, reaching out to specialists in Nairobi through this peer-to-peer telemedicine kind of solution. So that ecosystem thing is what we need to establish, and that to me is what will crack those behavioral barriers. Yeah.
Okay, well, thank you, all our panelists, and for the questions we didn't answer, I'm sorry about that, but maybe you can contact the panelists directly. But this was a good session, and we appreciate all your participation in this, and I thank you, especially the panelists, for the time that you took to do this.
Thank you, Denny. Also, thank you from my side to the panelists. I felt it was a very interesting session, and we had lots of questions in the Q&A. Sorry, I'm getting confused. And it's worth it to have these things online. I've already seen that people want to meet after that session to discuss if there's a way to cooperate. That's exactly what we would like to see. And it's great that this can also take place in a digital world. So it's all about digitalization and using it the right way. So it's lunchtime now, and I see you back in around 90 minutes. Bye-bye.
Thank you. Bye-bye.
Bye, everyone.
Bye, everyone. Bye.